Hi, good afternoon. Thank you, Dr. Abdullah. So usually I try not to present on hypertension or any other comorbidities except when related to heart failure anyway. So basically these are my disclosures, and we know we have been acquainted to this molecule, secretive valsartan or Entresto, for a long time, since 2014, since the start or the initiation or publication of the paradigm trial in heart failure with reduced ejection fraction, and how actually this has impacted the management of heart failure with reduced ejection fraction. Just before we start talking about this molecule, just a couple of slides just to show you that the role of natriuretic peptides, whether atrial natriuretic peptide or beta natriuretic peptide, BMP, their positive role, I think, on vasorelaxation, on diuresis, on reducing hypertrophy, reducing fibrosis. So they are, in a way, they reduce remodeling, and they have an adverse remodeling effect, and they improve the imbalance of increasing the activation of RAS system. Usually, whether ANB or BMP, usually they have cardioprotection effect, kidney protection, as well as vascular protection. And this is usually due to the anti-myocardial hypertrophy effect, a reduction in fibrosis, as well as inhibition of the sympathetic nervous system and RAS activation. And it has a significant effect also on systemic vascular resistance, renal flow, and vascular fibrosis. So they have multiple effects. But at the same time, these peptides, they can get cleaved and deactivated by neprilysin. Neprilysin deactivate or cleave these molecules and deactivate these molecules. At the same time, neprilysin can metabolizes angiotensin 1 and angiotensin 2. So if we block neprilysin for heart failure alone, this may increase angiotensin 1 and angiotensin 2. So in order to have a better effect, we need to block or neprilysin or inhibit neprilysin, as well as inhibit the AT1 receptor, or the effect of angiotensin 2 on AT1 receptor, which will lead to hypertrophy, fibrosis, vasoconstriction. And this is where this slide, you know it for many talks from previous in heart failure, but also can apply to hypertension too, because whenever we block renin-angiotensin-aldosterone system with valsartan and sacubitril to inhibit neprilysin, we can shift this imbalance of the activation of the RAS system and more activation of the natriuretic peptide, and this will lead to adverse or reverse remodeling. And we know that in heart failure with reduced ejection fraction, this was significantly impacted the treatment, and secretive valsartan or Entresto is one of the main pillars of heart failure with reduced. Also, there were studies on heart failure with preserved that I will come in the next stage of my talk, but I want to highlight hypertension first for this molecule. Actually, it was initiated first to treat hypertension before it was a heart failure medication. We have seen the ACC guidelines as well as the ESC guidelines in hypertension, and we know that the first-line treatment in green here, ACE inhibitor, ARB, calcium channel blocker, or diuretic. Then, if resistant or not intolerant or not controlled, we can add other molecules, including beta blockers and aldosterone antagonists in cases of resistant hypertension, and even other molecules like alpha blockers, etc. But usually we are here, as well as worldwide, still with all the management in hypertension, we are still not controlling blood pressure in these patients. And there were recently, not recently, over the last 10 years, several studies that have shown that this molecule, secretive valsartan, compared to olmesartan, has a better effect on reducing blood pressure and in controlling hypertension. This is the first trial where they compared the efficacy of sacubitril valsartan 200 milligram to olmesartan 20 milligram, and the hypothesis was to show that it's a non-inferiority of this 200 milligram compared to olmesartan in decreasing mean sitting systolic blood pressure from baseline, as well as for decrease in mean systolic blood pressure from compared to olmesartan. So this was a randomized trial, double-blind, parallel group, multi-center study of including around 1,160 patients. They were randomized 1:1 into either Entresto 200 milligram, 400 milligram, or olmesartan 20 milligram. The primary endpoint over 8 weeks of this study duration was reduction in the mean sitting systolic blood pressure from baseline with Entresto versus olmesartan at 8 weeks. And there were other secondary endpoints, including mean sitting diastolic blood pressure reduction, mean sitting pulse pressure reduction, and overall blood pressure control rate. These were the exclusion and inclusion criteria. Usually a patient above the age of 20. It was conducted in Japan with mild to moderate hypertension with a blood pressure 150/179 at randomization, and any of the following hypertensive history. One antihypertensive therapy within 4 weeks on antihypertensive therapy 4 weeks before screening, a newly diagnosed and never treated, or previously treated but stopped more than 4 weeks. Other exclusion criteria including severe hypertension and history of angioedema, stroke, or bypass during the last 12 months, in addition to pregnancy. This is the first primary endpoint. Mean sitting systolic blood pressure reduction. As we can see, there was, compared to olmesartan, there was significant reduction of 200 Entresto 200 milligram, as well Entresto 400 milligram, with a significant p-value of less than 0.01. With the 400 milligram, there was around 7 millimeter absolute reduction in blood pressure in these patients. When it comes to adverse effects, there was no significant adverse effect between the 3 groups. The only increase was in nasopharyngitis that was around 2% in patients with sacubitril valsartan compared to others. Other side effects that stopped the medication or interrupted treatment was equivalent to placebo. The second study also, because we know that monitoring ambulatory blood pressure is one of the important things to see if the blood pressure is controlled or not. So this was a 24-hour blood pressure lowering efficacy of sacubitril valsartan versus olmesartan in Japanese population too in essential hypertension. So there was a run-in period, and they randomized 632 patients, also either Entresto 400, 200, or olmesartan. Over 8 weeks, the change in 24-hour daytime, nighttime blood pressure from baseline were studied, as well as whether they are dippers or non-dippers, and there were several secondary endpoints, including change in 24-hour blood pressure, change in biomarkers, etc. And we can see here the first results of this trial, and we can see that Entresto, whether 200 milligram or 400 milligram, significantly reduced blood pressure over 24 hours compared to olmesartan in systolic as well as in diastolic blood pressure, with a significant p-value, even in non-dippers also, whether at 24 hours there were significant reduction, whether at 200 or 400 milligram. In daytime also, the primary endpoint in non-dippers was also significant, as well as in nighttime, there was significant reduction with the 2 doses of 200 and 400 compared to olmesartan in this population. So in conclusion, from this study, the treatment with sacubitril valsartan in patients with a non-dipper profile of nocturnal blood pressure confirms that this agent has a potent 24-hour blood pressure lowering effect in this Japanese population. The third study is the effect of sacubitril/valsartan compared to olmesartan on cardiovascular remodeling in these patients. So the objective was to evaluate the effects of INTEREST-2 compared to olmesartan on cardiovascular remodeling in patients with essential hypertension. And this has been measured with the change in local distensibility by MRI of the ascending, proximal descending, and distal descending aorta at 52 weeks. They included 114 patients aged more than 18 years with essential hypertension, randomized to 200 or 4 milligram of sacubitril/valsartan versus olmesartan, which can then increase to 400 milligram versus olmesartan increased to 40 milligram in these patients. And if the blood pressure was not controlled, amlodipine was allowed. And we can see that amlodipine was prescribed more in the olmesartan group, 30% versus 17% in the INTEREST-2 or sacubitril/valsartan group. At 52 weeks, in addition to reduction in systolic blood pressure sitting and central pulse pressure, which was significant, there was significant reduction in LV mass index 2, signifying remodeling in these patients. In addition, there was reduction in pulse pressure too that I will not show here because of the sake of time. The fourth study that I will show you was blood pressure reduction with this molecule INTEREST-2 compared to also a comparator in this. It was a randomized double-blind placebo-controlled trial too, showing a reduction in different settings, INTEREST-2 alone with different doses, valsartan with different doses, and sacubitril alone in these patients. And we can see also just the same thing, that with the INTEREST-2 200 and 400 milligram, there is compared to the valsartan 160 and 320, there is significant reduction in systolic, diastolic, and mean pulse pressure in these points. Also, secondary endpoints like 24-hour ambulatory blood pressure at 8 weeks was also, whether in the daytime and diastolic and pulse pressure was also all were reduced. This is just to show the effect on kidney disease with INTEREST-2 compared to valsartan, showing a better reduction in urine protein, less reduction in GFR, increase in GFR compared to the other, or less reduction, and less increase in creatinine level in the sacubitril/valsartan group to valsartan group. And this is signified that this molecule has a kidney protection effect in this population. And on long-term safety profile in this population also, there is another study, whether at 200, 400, or it was reduced to 100 in case of hypotension. And we can see that the serum potassium level reduction was low, 2.6%, an increase of potassium more than 5.5 was only on 0.9% in this population. And at 52 weeks, there was persistent reduction in blood pressure, whether systolic or diastolic blood pressure. So it is an effective molecule in reducing blood pressure compared to the other antihypertensive medications that have been studied or recommended in the guidelines. If we want to switch from ACE inhibitor or ARB, it's easy. For ACE inhibitor, we have to stop for 36 hours. And the recommended starting dose is 200 going to 400 milligram in this population. This is in hypertensive patients, but in heart failure patients, we would like to follow the guideline recommendation to have it a BID dose or twice daily dose. Saying that about hypertension, I will move to the heart failure with preserved ejection fraction and try to correlate both in the same setting. We know that heart failure with preserved ejection fraction, for a long time, there were a lot of negative trials up till recently over the last 10 years or 7 to 8 years. There was showing some positive trials in heart failure with preserved ejection fraction. And recently, there were many trials, including the Fine Heart, HFpEF, the liver, in SGLT2 class molecules, etc. But I want to highlight about the Paragon trial. though it was negative trial that missed the p-value with a p-value of 0.059, which was in a HFpEF and mildly reduced ejection fraction, selective valsartan versus valsartan, so it was compared to a comparator in this population, but they didn't include urgent heart failure visits in this population, and this population too. And if they include heart failure visits in the population, then the p-value would have changed to 0.04, and this will be a positive trial. This is for the primary endpoint of recurrent heart failure hospitalization or cardiovascular death. Also, for heart failure hospitalization, this was missed the primary endpoints. But we have learned from the pre-specified subgroup analysis that females, they do better, and a median ejection fraction less than 57%, they do better. So, selective valsartan has been shown from this Paragon trial to have a better effect in mildly reduced or ARNi-F less than 57% mean or less than 60 in females, as well as in female patients, as well as in low ejection fraction or heart failure with mildly reduced ejection fraction. And this is just to combine paradigm heart failure and the Paragon trial, showing that the effect of selective valsartan in heart failure even exceeds up to 55-60 per ejection fraction in this population. But this was not reflected in the guidelines. It was a class 2B given in the indication in 2021 and 2022 guidelines, just because the study was negative as the primary endpoint. Also in 2022 ACC guidelines, ARNi was a class 2B indication in this population. But we know that in HFpEF population, around 60 to 80% of them are hypertensive too. And in the next publications that has been published on as a consensus document in heart failure with preserved ejection fraction in 2023, in the American side and European side, they profiled the patient of HFpEF depending on different comorbidities. And actually, we can see that in arterial hypertension HFpEF patients, they mentioned that ARNi is one of the treatment arms in this population. Also, in the management, in the ACC consensus document too, they mentioned also that in patients with a profile of hypertension and HFpEF, diuretic agent ARNi, ARB, and MRA can be prescribed. So in this population, which is more than 60 to 80% of our population of HFpEF, we have hypertension in this population. And another thing, there is a meta-analysis or network meta-analysis in patients with mildly reduced and preserved ejection fraction, showing like in heart failure with reduced ejection fraction, giving the 4 pillars, ARNi, beta blocker, MRAs, and SGLT2 inhibitors actually reduce the primary endpoint, cardiovascular death, as well as hospitalization for heart failure if we give the 4 pillars in this population. There are some question marks on beta blocker, but there are ongoing trials in this population, and this too. So I will end here, and I am on time too. The selective valsartan has proved its efficacy in heart failure with reduced ejection fraction over more than 10 years. It proved its efficacy in HFpEF patients with an EF less than 60% and in females. It proved its efficacy and safety in hypertension patients. We have to remember that 80% of HFpEF patients are hypertensives. We have to remember that there is an efficacy in kidney safety and improvement in kidney function. It has an effect on LV remodeling and vascular stiffness. And in the recent consensus documents in the HFA and ACC, ARNi in hypertensive is recommended. Thank you.
Thank you very much, Hadi.